So I'm going to introduce you a fantastic colleague that's been here for a few years now. Came from different institutions around the country, Memorial Sloan Kettering, Dartmouth. She's one of our surgical oncology docs, fantastic doctor, skilled surgeon, super smart, and a good friend. So to talk to you about where we are in the surgical approach to melanoma is Dr. Christina Angelis.
Thank you for those kind words. It's such a pleasure to be with all of you today in person and all in virtual, to be able to speak to you as a whole instead of just individual patients is very special to me. So I thank the whole, our team here and also the AIM Foundation. So as a surgeon, it's been really exciting times over the past, several years, because we've also had a lot of changes. And where you'll see maybe in the systemic therapy world, there wasn't a lot, and now there's more. In surgery, it's almost the other way around. And I'm going to kind of show you that today. And then I'm going to end with a little bit of what we're doing in my research group. I have a basic science lab. So these are my disclosures. We do have some research funding to the institution and also for my lab. Let me see if I can close this. So our history gets to go way back in surgery. Back in the 1700s, we didn't even know what melanoma was, but there was a description of these black tumors, metastasis throughout the body, this black fluid. And one of the first surgeons that there's actually a documented surgery for melanoma was in 1757. And I put an asterisk next to melanoma because we didn't actually know it was truly melanoma until 1960, when the specimen was taken out of the museum and tested. But surgery has been used for melanoma for a long time. And then in the late 1800s, there was this thought, Dr. Herbert Snow wrote in the Lancet that, just taking out the primary melanoma where you first saw it was ineffective. And this concept came about that you have to remove all the lymph nodes, so the draining lymph nodes of where that first melanoma site was. And that was going to be more effective. This was a very controversial idea when it first came about. And then another surgeon, Dr. William Hadley, did a lot of research and also was a surgeon, and then wrote his findings and said, actually, we need to do a really big excision. If you can imagine 2 inches around a spot on either side, we're talking about a huge excision, and you have to remove all the lymph nodes in that area. And this was written up in the Lancet, which was a very prominent medical journal at the time. And this really guided surgical treatment for over 50 years in the 1900s, okay? And I'm showing, if you can see here, I wonder if you can see my arrows. So just to give you an idea, right, if you have a melanoma, let's say on the arm, and then all the draining lymph nodes here under the arm would be removed. Now let's fast forward to today. Today, melanoma, we're all here today because we still know that it's present, cancer with the highest yearly increase in new cases. As a surgeon, though, I see a lot of patients that are where melanoma is detected a little bit early, it's localized, and patients are cured when we detect it early, like you heard from Dr. Lau, and you have an appropriate surgery. And I do a lot of these wide excisions, which can be curative for very early. When I say early, it's thin melanomas that haven't spread yet anywhere. And there were 6 randomized controlled trials because surgeons said, wow, we can't take all the skin off of a patient. And, it's hard to close, and the morbidity, which means a lot of complications to try to do that. And is it really helping patients? So this is where surgeons said, hey, we're disfiguring patients. Let's find a way to maybe it's safe not to do that. And there were 6 trials where they randomized patients with melanoma to either a small incision or a big incision, 1 versus 4, 2 versus 4, all the different. And it came up with now today, we don't do more than a 2 centimeter, which is the max at 3/4 of an inch. You can think about that compared to what they did prior. And there was no difference in survival for any of these margins. Actually, the wider margin never improved survival, how long a patient would live with these. And given all this, even today, even though we've got it down to 3/4 of an inch, there's a randomized controlled trial going on right now in centers, it's a international trial in the States and others, where now we're seeing, can we even go smaller? Maybe 2 centimeters isn't even needed. And is there a difference in the risk of melanoma recurring either at the site or somewhere else if we can get even smaller? So again, showing that even though surgeons like to do surgery, we also want to make sure that we're doing the right thing and not doing too much that's not needed. Now let's talk about removing all those lymph nodes. That was another thing, right? That was kind of the expected dogma, right? We got to remove all the draining lymph nodes. And an elective dissection is when we remove all the lymph nodes, but there's no evidence of disease. We can't feel any, we don't see any, but maybe there's disease there. So that's an elective dissection. And again, surgeons said, we're taking all these lymph nodes. There are side effects when you remove all the lymph nodes in a basin. I'll give you an example. If you remove all the lymph nodes here in the groin, there's a decent chance that you could have a big swollen leg for the rest of your life, right? And there's things that we can do to mitigate that. But again, are we doing it for the right reason? Are we giving patients the risk in the right context? Are they going to get a benefit? And there were 4 trials that actually looked at just taking out lymph nodes on all patients, if you don't see any lymph nodes, don't feel any, and it never showed any benefit. So this led to this is kind of one of our very special surgical oncologists, Dr. Donald Morton, who developed this idea of not removing all the lymph nodes, but instead finding a way to take maybe the first drainage lymph nodes to see if there's melanoma there. And after a lot of research and trials, what they figured out is that melanoma or anything, even if you put dye somewhere, if that drains, it's not going to go to all the lymph nodes in that region equally. They will go to the first primary drainage point or sentinel lymph nodes first. And so this really changed how we would treat patients. So for the appropriate patients, we would inject dye in the area of the melanoma. It travels to the sentinel lymph nodes. Give you an idea, you have about 30 lymph nodes under your arm in that axilla area. And typically the dye will go maybe 1 to 3. That's kind of typical. And those are removed. You can see in the operating room, we use this radioactive dye. We take pictures so we can see. You can see here, we inject the dye and then we see these little spots. That's where the dye went. And in the operating room, we also use a blue dye. It's really cool. We can see here's a lymph node with that blue dye. So I know, hey, that's the sentinel node. Take those out, send it to the pathologist. They look under the microscope and say yes or no. Right? Is there melanoma or there not? And if there's no melanoma there, now we just allow those patients to keep all their other lymph nodes. So this was really a big change in care. Now, of course, the patients who had melanoma in their lymph nodes, we took them back to the operating room and we took all their other lymph nodes out, right? Because if there's microscopic disease there in 1 or 2, then there's a chance, right? It can be in all the other ones. And so again, we did this for many years. This was standard of care when I started as a surgeon in 2014. We took all the lymph nodes out. And then we said, wait a minute, is that helping patients, right? Because we're still seeing recurrence. We're still seeing patients after we take all their lymph nodes that get disease. So let's actually answer the question. Again, there was 2 randomized controlled trials that I'll tell you about. But the important thing that we saw as surgeons, we would do all these lymph node dissections, and about 80 to 85% of our patients would have no other melanoma cells in the lymph nodes we took out. So take out 20 lymph nodes all without. Of course, there were patients, those 20% that did, and we felt good about that. But all those other patients, we didn't feel good, giving them the risk and probably no benefit. And so there was 2 trials that were put together that we said, okay, let us either randomize them to remove all the lymph nodes. Again, this is if they had a positive sentinel lymph nodes. This is patients that we know they had microscopic disease in at least 1 lymph node. Let's remove all the lymph nodes, or randomize them to let's watch them really closely. And this was designed in a very thoughtful way. We did not want any patients to get harmed by this. So we wanted to watch them very closely. So we would see them back every 4 months. Some of you might be on this right now. See you back every 4 months. with an exam, use an ultrasound at that nodal basin to see if there's any disease that's there. And if on ultrasound, one of the lymph nodes, at least one of the lymph nodes looked abnormal, and they can pick up very subtle differences on these ultrasounds. You can see a little area of melanoma. Then we would do this completion lymph node dissection, thereby saving, right, the 80% of patients that didn't need that. So we knew that we were going to see about 20% of patients that had this, and we would have to take them. We knew that, right, from our data before. But now we said, okay, well, is there a difference in survival? And there was no difference in survival. So whether we waited for that 20% to show us, hey, we need our lymph nodes out, or we did it up front, there was no difference in survival. Again, doing less surgery, preventing surgery that we don't need. Now, for our patients that have melanoma that don't have evidence of disease anywhere else, that we take to the operating room to do that wide excision, there's a certain group, if they have a thickness of their melanoma, at least 0.8, the general guidelines is that we check that sentinel lymph node. Again, there are plenty of patients who that sentinel node is negative, but it is a very important, the sentinel node biopsy has been shown to be one of the best markers for us in terms of prognosis, how you're going to do as a melanoma patient, what's the chance of recurrence. So it is a very important procedure. But again, the question comes up, are we doing too many? Are we doing too much surgery? Are we taking patients to the OR to do these biopsies that don't need them? And so there's an ongoing trial right now. It's a prospective registry trial. It's going on at 8 cancer centers throughout the country. We're one of them that's actually looking at the primary melanoma, the gene expression and some clinical characteristics. There's an algorithm that was designed, the Mayo Clinic with some of my colleagues along with a company, Skyline DX. And the question is, can we determine who would have a negative sentinel lymph node? So we're not trying to decrease care for patients that need it, but the other way around, can we find a group of patients that their risk of having a positive sentinel lymph node, having disease in the node is so low that we don't need to do it. And so before they go to the operating room with any of us to have their sentinel node biopsy, we send their primary melanoma to do this expression. And now we're following them out 5 years to see if we can kind of associate it, to see if there's actually a prediction that we can do who has a very low risk of melanoma. Again, trying to do less surgery. So we also have a role in more advanced disease. Now, I'm telling you, we're doing less surgery, but, still today, if someone does have bulky lymph node disease, we can feel them, we see them on imaging. Patients don't have disease anywhere else. There is still the standard of care is for us to take out those lymph nodes. Okay, so that is something that we still do. I don't want you to think the surgeon's not going to be doing anything. And you heard from Dr. Lau that there's recent clinical trial data that suggests that if we give that immunotherapy before surgery, this may be beneficial for the best outcomes, right? So now we have patients that might have this disease, and if you give immunotherapy, there's a good response. And then there's those T cells that you heard about that they have memory. They see a tumor and then they have memory. Now you have this army of T cells with memory to your tumor. And then we go and cut it out. And we think that might work better. So that might allow us to do even more surgery. And then this is a big change that has happened since I was a medical student. I learned when you had a patient that had stage 4 disease, where you had patients that had melanoma in different places, because of the data that you heard about before immunotherapy, that there was no role for a surgeon, right? Because there was no use to take them to the operating room. And that has changed drastically. Now we have patients that go on immunotherapy, and we hope that all the tumors are going to go away or be stable. That's great. Occasionally, though, a patient might have a good response, disease shrinks, but maybe there's one lesion that progresses, that grows, that we call like a resistant tumor, but all their other disease is stable. This is where the role of surgeons has now come into these patients, which is really, a change that I've seen just in the past few years. And there's data that's suggesting that the patients have improved outcomes in this. So they have stable disease. You go in. I have a lot of patients now that we've been following that I go in, that I remove one tumor, and then, another years go by and they still don't have progression. So this is really exciting for us as surgeons. So while we're doing less surgery in some cases, reducing unnecessary procedures, reducing risks and side effects of things that aren't done, we're now doing more surgery with this advancements of systemic therapies and overall improved outcomes for our advanced melanoma patients, which is a really exciting time for all of us. And why? Why can we do this? It's because of all those clinical trials. And the only way that we can make these advancements is because of you, right? Without the patients being part of these trials, we would never be able to make these advancements. So a big thank you to all of you. And the patients, unfortunately, there's some patients that aren't here with us today, right? That they didn't survive, but they were on these trials that are allowing us now to have the next group of patients have more survival, right? And this is really something that's humbling to watch, all of us as practitioners, that you guys do this for us. It's not for us, it's for you, but it's for all of us. Okay, I'm gonna switch a little bit and put on my other hat for a second. So I have a basic science lab, and one of the big things that has always driven me to do research is, while I care for patients, there's so many of you that do well, but there's the patients that don't. And it's hard for me to go and care for you every day and not do something to advance what we're doing. And so while all of this advancements in immunotherapy has happened, there's been the patients that don't respond and don't do well. And I've always been fascinated about, well, what about those patients that do well? What is so different about their immune system? What can we find out about that to try to induce that in patients that don't respond? And so a big focus of my research group is really focused on those best responders to immunotherapy. And the way you saw the Pac-Man, I love the Pac-Man. I don't have Pac-Man today, but the way this works, it promotes these T cells to respond to the cancer. This is not Pac-Man, but it's a very similar thing, right? Where the immunotherapy, the way it works is that it blocks the shut-off button. You heard about that with Dr. Lau, right? And so T cells will see tumor and bind to it, or sometimes there's other immune cells that will take a piece of the tumor and show it to the T cell. And this makes a big immune response, right? That T cell then secretes messages to all their friends and they say, come to the party, we're going to kill the tumor. And when that happens, the human body is really kind of smart, and it has automatic shutoffs, which you heard about, the checkpoints, blocks, to reduce that immune response. Because if you just have this immune response that never stops, you can actually have a lot of side effects. And so there's multiple checkpoints. If you block some of them, it allows that to not turn off and go and have a good response. Of course, the side effects of that, you can have inflammation, right? Because you have this big immune response. One of the side effects that we see in patients that go on immunotherapy is something called vitiligo. Now, this is, it changes the pigment in your skin. So you can have patches of white. Some of you might have had this. One of the things that we noted when we started giving immunotherapy is that there are some patients that will get this. And when you look at their outcomes, how they do, a larger percentage of them do better. They have more complete response, meaning their disease goes away, or they have more stable disease than patients with other side effects, right? You could have inflammation in your bowel, inflammation in your skin, but this specific one where you actually lose pigmentation in your skin had a better response. This was fascinating to me. Like, why? Why the patients that are losing their pigment doing better? What's happening with those patients? And so I'm not going to get into all the background, but we've did a lot of research, my group and others, looking at what goes on in this vitiligo system in mouse models, and also just the idea of what T cells can create vitiligo in the non-melanoma patients. So just some patients have vitiligo from an autoimmune disease that has nothing to do with melanoma. And so with all that, what we figured out is that there's actually, when this immune response happens, there are some T cells that have memory. once they see something, they remember it. If they multiply and divide, they all have the same memory to the same thing. And in the tumor or the skin, you can develop these special T cells that are resident, meaning that they stay in the tissue or skin. They don't circulate in the body. And when you have those in the skin or tumor, you can have this vitiligo. So my question is, what's going on in those patients? Now, can we go look at those patients and figure out what's so important about those cells? Because maybe that's the key to the better survival. I don't know. So we designed a trial where some of my patients that developed vitiligo after immunotherapy, and they were long-term survivors, we called that 3 years after starting therapy, and the disease either went away completely or was stable. We took their blood, their skin, and their tumor and did this whole process where we took out the T cells and did a special study where we looked at all the gene expression. So every cell has a certain message that tells it what it should be. And we can actually do this high throughput sequencing to look at that gene expression. I'm not going to go into this, but just to give you an idea, what do we get when we do something like that? We get these big plots of all these different kinds of T cells. You can see these are different types of T cells. These CD8 ones are the ones that actually kill, right? That are kind of the prime T cells that attack melanoma. And we saw all these different groups of T cells. And we went in there and started to really figure out, well, what are the important ones? One of the cool things that we found is that there's a specific T cell, this resident memory that has a message that says stay in the skin or stay in the tumor, that had a high expression of these effector markers, meaning like we can go kill tumor, and a decrease in those checkpoints that we talked about that turn off the immune system. These were high. I mean, the markers were low. The exhaustion markers were low, meaning that they were more effector looking. And when we took this signature and looked at databases of patients and their survival, the patients that had this signature had more overall survival, right? So again, saying, hey, something special about these cells. And then when we went back and we could actually match these cells, the patients that had these specific cells in both their blood, their tumor, and their skin, matched signatures, did the best. Okay, so this was like really exciting to us. So then I went back and said, okay, so here we have these patients. We're looking at these cells in their skin, in their blood, and their tumor. Do you think, when did they come about? So some of these patients had banked tissue. You can imagine if we see you today, but you might have your primary melanoma that you had 9 years ago, 6 years ago. So we went back and matched these to their tumors 6 years ago, 9 years ago. You can actually do that. You can actually take that signature and see if it's, where did it start? Where did that T cell first see tumor? And what we found is that they were durable, lasted for years. And so now the next step is, can these functional resident memory T cells predict who can respond to immunotherapy? Are they required for immunotherapy to work? And if so, how do we induce them? So now we're really working on when can we try to induce these, maybe at the time of primary melanoma. I want to thank you all. I get very excited. I could talk about T cells all day. But thank you all. And again, really thank the melanoma patients for all our work.